In this podcast episode, two expert hematologists discuss clinical trial updates in chronic lymphocytic leukemia, presented at the 66th American Society of Hematology annual meeting held in San Diego, California. The discussion focuses on novel agent combinations in treatment-naive CLL, including BTK and BCL2 inhibitors, as well as novel agents being investigated in the relapsed refractory setting. Our guests are hematologist Dr. Versha Banerji from Max Rady College of Medicine at the University of Manitoba in Winnipeg, and hematologist Dr. Jennifer Brown, director of the CLL Center of the Division of Hematologic Malignancies at Dana-Farber Cancer Institute, and the Worthington and Margaret Collette Professor of Medicine in the field of Hematologic Oncology at Harvard Medical School in Boston, Massachusetts. Hope you enjoy it.
I'd like to start off by thanking Impact Medicom for inviting me here today to share some highlights from the clinical studies in CLL that were presented at ASH in 2024 and how they may impact the current treatment landscape. My name is Versha Banerji, and I am a clinician scientist at the University of Manitoba in Cancer Care Manitoba. And I have with me Dr. Jennifer Brown, who will provide her perspectives on CLL data presented at ASH. I'd like to now pass it over to Dr. Brown.
Thank you, Dr. Banerji. I'm Jennifer Brown, Director of the CLL Center at Dana-Farber Cancer Institute and the Worthington and Margaret Collette Professor of Medicine at Harvard Medical School. I'm happy to be here today and look forward to the discussion.
I'd like to start off by looking at first-line studies in CLL, and there was a lot of data covering targeted agents with oral combinations of BTK and BCL2 inhibitors. We saw numerous abstracts reporting on the venetoclax plus ibrutinib combination. Now we also have some second-generation BTK inhibitor combinations with acalabrutinib plus venetoclax and with or without obinutuzumab, as well as zanubrutinib plus venetoclax. There was also some novel combinations of second-generation BTK inhibitors, zanubrutinib plus sonrotoclax. So I guess the first question is, what's your opinion about some of the current data that was presented on Ven-I and the potential for its impact in clinical practice?
So the oral presentation on Ven-I was an update of the FLAIR trial, which FLAIR has studied a somewhat unusual regimen where they do MRD guidance every 6 months. So they're measuring MRD every 6 months, and then the patients get treated until they reach undetectable MRD, and then for that same duration of time after. So it's a much longer course of therapy than was approved based on GLOW, which we'll get to in a minute. And so they looked at predictors of who's likely to get early undetectable MRD, and they found that was strongly associated with unmutated IGVH, which is consistent with results from other studies, and then also people with low TLS risk. And the low TLS risk part makes perfect sense because it means they have less disease. So it's easier to get their disease below the threshold of detection. And, I think what I continue to take away from FLAIR is that the duration of therapy is very long. Only about half the patients can stop at a little over 2 years. And with the mutated patients, only half of them had stopped at 4 years. So I think those patients are really getting overtreated. It may be that the FLAIR approach is good for the unmutated patients, and we'll see more with time. They also reported on relapsers, and there were only 8% of the patients who've relapsed thus far. But it's very short relative to the long duration of treatment. They haven't had a long time off treatment yet. So we're really going to need more follow-up to see that. And in terms of the sort of benefit of the typical regimen, the GLOW regimen, which is the 15 months, 3 months of ibrutinib, and then 12 months of combination. And that's, of course, is the regimen approved in Canada, but not available in the US and not expected to be available in the US. So they updated that with 66 months follow-up. And the mutated patients have a 76% progression-free survival. So 3/4 of them haven't even progressed now at over 5 years. And so treating them for all the duration of FLAIR, is really probably unnecessary, right? The unmutated patients had about a 42% PFS. So they're having like the usual 5-year-ish PFS that you get from a 1-year time-limited therapy, similar to Ven-Obin, right? It still seems to me that the PFS that we're seeing after the 15 months of I plus V and the year of Ven-Obin is pretty similar. So it'll be good once we have some head-to-head comparisons of those regimens.
Yeah,
Now, how do
very
you
much
think
agree.
this will be used in Canada potentially?
So that's a really good question. And I think it kind of leads to some of the studies we'll speak to next. And I think although we have it available and it's soon to be funded in multiple provinces, I think the challenge in Canada lies with resource utilization and the uptake of Ven-O as a frontline therapy versus a double oral agent. And so I think from a resource utilization and cost effectiveness perspective, there's the balance that I think stress oncology units across Canada are facing, and a double oral therapy is super attractive. But I think the hesitance that arises from the clinical end is obviously the unpredictable toxicities of ibrutinib, which continue to kind of cause hesitation in who should we be giving this double oral therapy for as it has been approved. We don't know if we're going to have our choice of second generation BTK inhibitor, but I think that's a perfect segue into some of the exciting data that was presented, which was, I think, new, which was the Amplify data. So I was wondering if you would talk to me in general, Dr. Brown, on your opinion of utilizing the second generation BTK inhibitors and some of the data that was presented around Amplify.
Yeah, well, so Amplify, of course, is a registration trial for acalabrutinib, venetoclax, plus minus obinutuzumab compared to chemoimmunotherapy. And it's our first registration trial for second generation BTK with venetoclax. And so personally, I'm very excited about this because I haven't used ibrutinib in years. And even if I plus V were approved in the US, I wouldn't use it because I don't want to use ibrutinib. So the opportunity to potentially use acalabrutinib and venetoclax, again, with or without obinutuzumab, is great, I think. So Amplify met its primary and its first secondary endpoints, showing that AV and AVO both were individually better than chemoimmunotherapy. The estimated 3-year progression-free survival was 66% with the chemo, 76% with AV, and 83% with the addition of the obinutuzumab, the AVO. Undetectable MRD was highest with AVO. There was also an improvement in overall survival with AV compared to chemoimmunotherapy. The safety was really pretty remarkable, I think, for the AV. Neutropenia was the most common toxicity across all arms, but febrile neutropenia was rare. And there's only a 10 to 12% rate of grade 3 infection on the AV. So to me, the AV is something that we could use for pretty much any of our CLL patients. And, I see some of my older patients who are currently doing continuous therapy, potentially instead doing the 14 months of AV and being able to get off therapy. And then I was also impressed that I do think the obinutuzumab is adding to the AV, similar to what we saw with Elevate TN. And I am a believer in that. So I will probably use the 3-drug regimen for my sort of younger, fitter patients where you really want to maximize your PFS and where a little bit higher rate of infection and neutropenia is something that's pretty easily manageable for them.
Yeah, I think our, we're going to have to review this, and there's probably going to be a lot of discussions. I don't think it's going to be simple to just substitute the first generation with the second generation BTK inhibitor. I think we're all very excited about this combination, and similar to the overall survival benefit that was seen with the addition of obinutuzumab, or at least a trend towards that with the Elevate TN study. There are some provinces in Canada that have the ability to do a CALA-O. That's not true for the rest of the provinces. But I think for the ability to see a time-limited treatment that can be used across all age categories and multimorbid patients, which has an excellent safety profile, and in the Canadian healthcare system is publicly funded, that can decrease the cost of continuous therapies is so attractive. And so I think one of the challenges is, just like the Elevate TN, the study wasn't powered to compare the two acala-containing arms. And so as a result, I'm not sure if the Canadian landscape will allow for both therapies, or just the one that is, from a safety perspective, a little bit easier to onboard, no resource utilization with the obinutuzumab. And certain provinces may fund the triplet, but I think that will be a discussion that will be very interesting in the Canadian environment in the near future. So I think that is really where we're heading on the Canadian side. And so that brings us to the combination of, I guess, second generation BTK inhibitor, but also with a new BCL2 inhibitor for zanubrutinib and sonrotoclax. And how do you think this data fared at the presentation at ASH this year?
I think it looks pretty exciting. In vitro, sonrotoclax is tenfold more potent than venetoclax and also has activity against the primary G101V resistance mutation. So that is encouraging. And, it's a large phase 1 study in multi-center, but it's still probably mostly CLL centers, pretty highly selected population. The undetectable MRD rate at a year was 90%, which is much higher than we've seen with the venetoclax containing BTK BCL2 combinations. And so whether that holds up in the registration trial or not, it almost certainly won't hold up at quite that level, but it'll be interesting to see how it'll be compared to Ven-O in the registration trial, which is actually almost completed accrual. So that's also another study comparing BTK BCL2 to Ven-Oben, along with the MAGIC study comparing Acalabin to Ven-Oben. So we are going to get some second generation inhibitor comparisons to Ven-Oben, fortunately.
Yeah, I think that's an exciting environment to be in right now. And the opportunities we have for our patients have expanded greatly. And also, even for ourselves, we'll be able to tailor the treatments which are most appropriate for each individual as well. I know you had mentioned earlier that, you would definitely use the triplet in that young fit population. Do you feel the same way with all the triplets that are now being evaluated, ibrutinib Ven-O, Acala Ven-O, as we talked about, but also Zanu Ven-O?
Yeah, that's interesting. I'm not sure I do. We don't have comparative. And technically Amplify is not comparative data, as you pointed out, because it wasn't powered to compare the AV versus the AVO, but at least it was similarly conducted, similarly enrolled patients randomized to one of the three arms in terms of data, and similarly Elevate TN has the same advantage of the open addition. I think we still need more follow-up and more multi-center studies of these other triple drug regimens before I'll be convinced. Also, the PFS for the ibrutinib Ven-Oben regimen, which was done at Ohio State, was reported because that one has a lot longer follow-up, right? And so the median PFS is only about a year longer than Ven-Oben. And so is a year longer worth 14 months of a BTK inhibitor and exposure of the disease to a BTK inhibitor when you could otherwise save the BTK inhibitor for later? I'm not sure. So, we'll see.
Yeah, and then the toxicity piece, I think, is the other part, right? In all the head-to-head studies with doublets versus triplets, there was very little gain in PFS and significant increase in the toxicity profile. And so I think that's also, from the Canadian perspective, one of the things we have to balance: access to emergent or urgent care with infectious complications. And so that's something that has limited our enthusiasm, I would say, and also because of the cost of the triplet for probably not a big difference in efficacy and similar rates of undetectable MRD, at least with some of the frontline therapies that we've seen. So I think that now allows us to shift some of the discussion to the relapse refractory setting. And so I think there's a lot of information that has come through on resistance to BTK inhibitors. And I think some of the novel agents that have been in review over the last couple of ASHs is the class of BTK degraders. And so what's your thought and opinion on how quickly these are going to be moving into clinical practice? In Canada, we don't have any access to these drugs outside of clinical trials. And some of the more advanced stage trials are coming to Canada, but they're just opening. So there's not a lot of us that have experience with the BTK degraders. So I just wanted to ask you your thoughts on some of the data that was presented at ASH and how and if you are using it in your practice.
Right. So there were two drugs presented at ASH that had also been presented at EHA 6 months before. One is a Nurix drug and the other is a Beijing drug. And they both look pretty promising, both at EHA and now again at ASH. The patients are very heavily pretreated, median of 4 prior therapies, and 2/3 or more of them have had BTK and BCL2 inhibitors and progressed on them. So the response rates are about 75% or so. The Nurix drugs showed data that they can degrade any of a variety of the most common resistance mutations. So that was interesting. And both of them had data that they get responses regardless of a variety of the most common resistance mutations. So that was all exciting. I think the follow-up is very short. 4 months for the Nurix drug and about 10 or 11 months for the BeiGene drug. The 10 or 11 months is starting to get it to be longer, and it looked like they had patients out, they both have patients out over a year, but in terms of the numbers, that's still relatively small. But so I do think it's encouraging. I think the toxicity profile may be a little bit more back to first generation BTK inhibitor, and it does look a little that way in these studies. We'll see. The patients are very heavily pretreated, of course, so it's not surprising that we're seeing some more fungal infections and bleeding events than maybe we've gotten used to in the frontline studies. So we'll see how that develops over time.
No, I was just I when some of the data was first released, I don't know why I miraculously thought some of those toxicities wouldn't exist, that we were so used to kind of getting over with the second generation BTK inhibitor. So I think it's important for us to realize that. And you're right, they're heavily pretreated, but it'll be interesting to note whether these patients saw chemotherapy or not. And in the generation that we have of patients that have never had chemotherapy, if there's going to be a different toxicity profile, or is this really specific to those that we know that we salvaged with our first generation and second generation BTK inhibitors, and now they've lived 10 extra years, but they're still part of that pre-treated chemotherapy treatment era patients. There was also some data on pirtobrutinib that was presented, one of the non-covalent BTK inhibitors. In Canada right now, we have only compassionate access to pirtobrutinib for patients who are double refractory to either a BTK inhibitor and a BCL2 inhibitor. And so the experience is growing with it, and it is definitely an avenue. So I wanted to get your opinion on the data that was presented, but also have you seen kind of similar trends in your clinical practice around that efficacy that was reported?
Right. So this is the first randomized trial with pirtobrutinib. It was approved in the U.S. Accelerated based on the enlarged phase 1 study, basically. And so this randomized trial was in the heavily pretreated setting, and patients had had covalent BTK inhibitors before. It's important to remember that because this is the first randomized trial that we've had that has actually enrolled that patient population. All the others had patients who had mostly had chemotherapy before. So that is of interest. And then so the comparator arm was investigator choice of idelalisib, rituximab, or bendamustine rituximab. And so the pirtobrutinib met its primary endpoint of improved progression-free survival. The PFS was about 14 months, which is less than the sort of 16 to 20 months that we saw in the large phase 1 trial. And the patients, again, were heavily pretreated and had high-risk markers. But, I think it underscores the fact that in these patients who have progressed on BTK and BCL2 inhibitors, many of them already have BTK resistance mutations. It becomes easy for them, probably many with pre-existing mutations, to grow out a new resistance mutation in the space of about a year or so. And I have to say that is more my experience with people who've had progression on covalent BTKs going on Pirto. So it is consistent with my experience, maybe more so than the phase 1, even though we participated in the phase 1. But we had this subset of people who, didn't get as much benefit because they have really bad disease and they already have pre-existing resistance mutations. And it's also going to be interesting to see how that pans out with the degraders, because there's potentially the same issue. We don't know what the mechanisms of resistance to the degraders will be, but there are probably mutations in BTK that can confer resistance. There is, in fact, already one report of a rare mutation called A428D as being causing resistance on the BeiGene drug, although there are also reports from the trials of patients potentially responding with that mutation. So it's a little bit unknown still. And you had asked me earlier if I had clinical experience with the degraders, and that's still pretty limited. Ours is also only on clinical trials. We're testing the BeiGene degrader in our clinic. We have 9 patients enrolled so far, so our experience is also pretty limited.
So in the phase 1, phase 2 study, there was also the data around the BCL2 exposed versus naive patients, and the PFS being potentially shorter. And now, from your knowledge and experience, do you believe that that's just a heavier pretreated population that is double exposed? Or do you think that there may be some thought around the sequencing, i.e., staying within the BTK class before moving to the BCL2 inhibitors in the relapse setting, or vice versa. So, I mean, currently in Canada, the way things evolved, time limited treatments are VR. So, most people who got chemotherapy have now been getting VR. And before they get to a BTK inhibitor, we do have a prevalent population that is on a BTK inhibitor. And then the question now is, if it wasn't for compassionate access and they had to be BCL2 exposed, should we be thinking staying within the BTK class and move on to the non-covalents and then go into the venetoclax-based therapies if it was widely available for whichever line of therapy? Do you have any kind of thoughts or suggestions? Do you believe that BCL2 exposure decreases the efficacy, or is it just that heavily pretreated population?
So that's a really excellent question. I don't really know the answer. I have a few thoughts. So my main thought is that it's probably just more line of therapy exposure. However, in the proto-resistance cohort where we looked at the mutational analysis, we do see BCL2 mutations from patients who've had prior venetoclax, and some of them do have increasing allele frequency during pirtobrutinib, and we've seen that in our experience too. But whether that's real as conferring relative resistance, I don't know, but it's possible. But on the flip side of that, so we did treat a number of patients on the phase 1 with Pirto before Ven. I have sort of a philosophy that if you have a good trial available at a time and you have an FDA-approved drug, you go with the good trial and save your FDA-approved drug for later, because you can always use that later and you don't always have a good trial. So I put a number of people onto the Pirto phase 1 who hadn't had venetoclax yet. And they did fine mostly in proportion to whether they had a lot of pre-existing BTK mutations, as I was alluding to before. If they had, this multiclonal BTK resistance architecture, they tended to grow out a mutation relatively quickly. So the question is, if you intervene with venetoclax in that group, would it somehow alter that clonal architecture, suppress the BTK mutations better, so that then you might do better with pirtobrutinib in that subgroup later?
Right.
Right. And those are unanswered questions that I think we really need to study. We really need this combination of the biology and the well-annotated clinical sequencing in order to figure this out.
Well, I mean, I think it's super exciting that we have all these options now, even in the second line setting. And now the time-limited treatments in the front line setting that might include some of the drugs that patients haven't seen, and they'll have multiple exposures, may also predict, the response to these further lines of therapy. And I think that brings us to kind of the last area of the, I would say, evolution in treatment in CLL that was demonstrated at ASH, which would be some of the bispecific antibodies. And so I think there's been a lot of enthusiasm over the course of the last couple of years on the use of bispecifics, mainly because there hasn't been as exciting progress in the CAR T domain in CLL. And so epcoritamab, which is a bispecific CD20-directed CD3 T-cell engager, was presented at ASH in patients who had been double refractory. And it's been an exciting area. We haven't had access in Canada, even through the Compassionate Access Program. It's only been available for more aggressive lymphomas. And so I would be very much interested in sort of understanding how you perceive the new data, but also has this been something you are able to access routinely in clinical practice?
So I think the EPCO data looked pretty exciting. The focus of this presentation was actually that they've added a cohort with another dose level, or not another dose level, but another step-up dose to try to minimize the toxicity. And they've also added pre-meds. They've changed from prednisone to dexamethasone, added hydration. And so that seemed to help a lot in the sense that they got rid of their grade 3 CRS, more or less. It's still a good number of patients were getting tocilizumab, but it was a lot better than it had been before. And so I think that's very useful for the potential use in the outpatient setting, which we hope to be able to do. They still see most of the CRS at the first planned highest dose level, not at the initial doses. And then the response rate is about 60%, which sounds a little lower than the degraders, but they have high rates of undetectable MRD. And then the durability of some of those are quite prolonged. And again, the patients were maybe even more heavily pretreated. It's definitely 4 or 5 prior regimens again, and a lot of 17p deletion, et cetera. So I think it looks exciting. I have not personally accessed it much. We have a number of trials for these BTK BCL2 refractory patients, and so I haven't accessed it. I have heard over the grapevine that some other people have, and they've been able to. So maybe we'll get some emerging data from real world studies around that. We've been really interested in trying to get clinical trials going where we move them to a consolidative setting. So you have patients who have gotten their frontline therapy, say, and we know they're not cured. Even if they have undetectable MRD, they're not cured. So maybe we could give them 6 months of a bispecific antibody then and get them in a deeper remission, extend their progression-free survival. And maybe this is a way, with multi-drug combinations that we can get closer to that elusive cure.
Yeah, and potentially decrease some of that genomic instability and reset the immune system to decrease some of the immune complications we see as well by eradicating the disease completely. And honestly, that leaves us on a very exciting note in the future for CLL. And I think I'd like to thank Dr. Brown for joining me in this great discussion. And it's clear that we have a whole bunch of unanswered questions. And I think that also leaves room for more excitement in the future and for us to gain more knowledge that will help and benefit our patients. So with that, I'd like to thank Dr. Brown for joining me and hope you have a great review of ASH and CLL.
It was a pleasure. Thank you, Dr. Banerji.